Okay, so we talked briefly about pneumoconioses, which are diseases resulting from inhalation of mineral dust. Coal workers' black lung, like coal workers' pneumoconiosis, silicosis, and probably the most famous is asbestosis. What happens is over the long term, you're inhaling these fibers. These fibers cause generalized inflammation in the area. Again, the more inflamed the areas are, then you're going to have water, you're going to have all the exudates that result from inflammation. You're not going to be able to diffuse gas from carbon dioxide to oxygen based on a concentration gradient. So there's going to be fluid and there's going to be scar tissue in between the alveoli so that diffusion can't occur, gas exchange can't occur. Specifically with asbestosis, you probably can't drive for more than a mile without hearing on the radio a law firm for mesothelioma and asbestosis relating from a lot of construction from the 40s, 50s, and 60s, and Brooklyn Navy Yard, all the city schools, a lot of the municipal buildings built with asbestos. And we'll take a look a little bit later. I'll show you the fibers of asbestos. These sharp, it's sort of like inhaling toothpicks, but on a microscopic level. These very sharp cylindrical fibers that end up getting into the lung tissue. And you might have heard of mesothelioma, which is a fairly rare cancer, and it's directly related to asbestos inhalation. Usually the lining of the pleura are involved. It can also be the pericardium. It can also be in the testes. So there's a variety of areas. But if we're talking about mesothelioma, usually you're talking about asbestos exposure. Tuberculosis, which is in the 70s and 80s was on its way out, and back in the early 80s, or middle to 80s, came back into significance, usually associated with HIV and the decreased immune system and the decreased immune capabilities of patients with HIV. You've probably heard of tuberculosis and multiple drug resistant tuberculosis and extremely resistant tuberculosis, etc. So on a national level, the incidence is basically on a fairly low level, decreased significantly. Again, resurfaced in the inner cities due to HIV. And there's a couple of different therapies. It's a bacillus which is just difficult to treat. But usually given a normal course of a couple of months or so, and you're probably familiar with things like INH, isoniazid, and rifampin, and streptomycin, etc. The problem is getting patients to be compliant, and the problem is getting patients to take the meds on a regular basis. So you've seen MDR and XDR. XDR is extremely drug resistant. We're talking about beginning with about 4 medications for approximately 6 to 9 months. And then we talk about second generation drugs, levoflox, the aminoglycosides, for another extended period of time, up to about 2 years. So you talk about Ziehl-Neelsen staining of sputum to have an accurate diagnosis. And what you should understand about what the PPD test is, and especially what your patients need to understand about the PPD test, is PPD is just going to say that you were exposed to tuberculosis, or that a patient's been exposed to tuberculosis, and probably everybody in the class comes back with a positive PPD and then argues with their occupational health person about whether they need an x-ray or what to do. But a lot of your patients, if you just get the positive skin test, think that they either have tuberculosis or they still have something going on because their arm still swells up, and patients need to realize that their arm's always going to swell. Once they've been exposed, you're exposed for life. So what you do need to understand is that if we talk about tuberculosis exposure, while it's airborne, etc., there's the number of particles that you need to actually inhale to come up with a positive exposure, a positive PPD exposure, and then there's an exponential amount of bacilli that you need to inhale to get the tuberculosis infection. So there's a big difference. This just talks about the vaccination and the BCG tests. Right. So we do both the sputum exams, like the Zeal-Nielsen staining, plus the blood cultures. And throughout the world, tuberculosis is typically a spinal disease, bone disease, and in the West, especially in the United States, tuberculosis is an airborne pulmonary disease. So patients who have back pain, patients who are immigrants, or if you're out in a different area and you're assessing patients, don't be surprised if they have spinal tuberculosis. And again, the absence of any physical findings doesn't exclude active disease. In the high-risk patient, put them in respiratory isolation, do serial sputum sampling. Treatments are going to have typically 3 basic principles. You use multiple drugs, you take them regularly, and for a long enough period of time. If we look at CF is a congenital anomaly. It's the most common lethal inherited disease in people of Caucasian descent. And it's a disease of exocrine gland function, not usually, but involving chloride ion transport. Okay? So, most commonly, people recognize cystic fibrosis as a respiratory disease, that there's sputum issues, etc., but there's also digestive complications. There's complications throughout the entire body, but mostly people are familiar with the respiratory issues, and these patients die typically of end-stage lung disease. If we look at the 80s, cystic fibrosis patients died predominantly in their teens or before 20, and now we're up till 35 or so, with a lot of different therapies being a lot more aggressive. So it's an autosomal recessive trait, again involving chloride ion transmission. Okay, so it's basically how water goes across cells, and if water transport is impeded, well, that means that you're going to get this thick mucus that the patients really have a hard time coughing up. You'll have the abnormally elevated sodium and chloride concentrations in sweat, so you might be familiar with a sweat test being diagnostic in a newborn. So overproduction, their inability to clear secretions, they get chronic infections, progressive COPD. And pancreatic enzyme deficiency, so they have a lot of malabsorption. They have steatorrhea, they have fat in their stools, they have clay-colored stools, so they're not absorbing very well. And again, if we went back and talked about first and second classes, when you have diseases and you can't absorb your vitamins and your nutrients appropriately, it's going to make it that much harder for you to fight off the disorder. So nearly every clinical manifestation is a result of an overproduction of viscous mucus or pancreatic enzyme deficiency. They also have reduced amount of bicarbonate. It impairs digestion. We talked about decreases and issues with pH. So the diagnosis